Hello, I'm Dr. John Kruse, and today I'm going to be talking about is ADHD part of post-COVID syndrome or long COVID. I'll be talking for about 25 minutes. Unfortunately, there won't be any question and answer today. I've actually did this live yesterday with a really bad Starlink connection and re-recorded it this morning, not knowing I had a really bad Starlink connection. This is the third trial, so this is recorded on the computer, not live. Some of the questions that were asked the first go around when I did this live, the information, some of that is incorporated into the talk now. And hopefully I will be back live next week. So as usual, I'll start with the take-home message. The take-home message is, the answer is yes, ADHD is part of post-COVID syndrome. So COVID, we have more than 36 studies that showed COVID had a bigger impact on those with ADHD in terms of decreasing functionality, causing more stress than the general population. So COVID itself had an impact on those with ADHD. But as we are starting to look more closely now at long COVID also commonly impacts, the most common symptom is fatigue. Probably the second most common cluster of symptoms associated with long COVID is brain fog, most of which are executive function, problems with attention, focus, concentration, organization of thought, motivation, that overlaps strongly with the executive function deficits of ADHD, and they are clearly the most common set of symptoms of long COVID, which are contributing to disability from long COVID. I'll get into that in the talk. So there's 3 levels where long COVID is interacting or part of the ADD picture. One is individuals who have ADHD to begin with, who also have long COVID, are at substantially increased risk for considerably more severe symptomatology and impairment. 2, people who had mild symptoms of ADHD, didn't meet the full diagnosis, had subsyndromal ADHD. Now, when they have long COVID, this doesn't mean all of them, but at least some of them are being converted from subsyndromal partial COVID to full-blown ADHD. So it's creating new cases by moving people further on the spectrum. And there's good evidence, at least some individuals who had no signs, no symptoms of ADHD before their condition, before they got the coronavirus, as part of their long COVID picture are displaying what might be called secondary ADHD. Looks just like ADHD, except the history is different, didn't start in childhood, but the whole range of ADHD symptoms and may well respond to some of the same treatments. So the end of the take-home message is that currently we don't have a vast amount of study on what are effective treatments for brain fog or ADHD-like pictures in long COVID, but the evidence that's coming out so far is that many of the treatments, both medication and not, that work for ADHD do work for the brain fog connected with long COVID. So to launch into it, we still don't have a clear, consistent definition for long COVID. Most of the definitions are coalescing around a few things. One is you have to have documentation that you really had COVID, so positive antibody or antigen tests are helpful, or in combination with symptoms of it. So long COVID by definition doesn't start till at least 12-16 weeks after the initial infection, because we know a considerable number of people with COVID, although the acute phase of the illness is usually just a few days to a week or two, there are many people who have a shorter than long COVID, but prolonged initial recovery from it. So again, symptoms existing at least 3-4 months after the active infection seems to have resolved as part of the definition. And we know that long COVID can last for months in some people, can last for years. Some people have had it ongoing without any remission. Some people have it for months and then it completely resolves. Some have it going on for months with partial remission, with or without treatments. What we don't also know is whether long COVID is predisposing to a post-viral syndrome where decades later some symptomatology may resurface. So that would be something like with shingles and chickenpox, or with herpes outbreaks, including herpes infections being reactivated in the brain, with post-polio syndrome where people had the polio virus and movement or paralysis when they were young, but then decades later some of them had a reactivation of either the virus or reactivation of immune attacks on nervous system. So we don't know how nasty this coronavirus is. It's been pretty nasty so far. So with long COVID, we know some of the risk factors for it. So your age, your older people are more at risk. In most studies, poor health to begin with, poor getting sicker during the initial acute phase of the infection is certainly a risk factor. So those who are hospitalized for COVID, between 50 to 70%, depending on the study, wind up with long COVID, as opposed to in the non-hospitalized population, 10 to 30%. And we know that vaccination provides protection not just against severity of acute infection, but lowers the rate of long COVID. So among the vaccinated population, most studies find rates of long COVID only in the 10 to 12% range. So there's also some evidence, not completely consistent, that which strain of the virus you had. So there's some evidence that the alpha, the first strain that was widely circulating, carried a greater risk for long-term COVID, and that does seem to be separate from whether or not, when most people had long COVID, we didn't have any effective treatments for it, so that compound, so many people got sicker from the acute infection. But there is some evidence, even controlling for severity of initial infection, which viral strain may predispose, with evidence that Delta and Omega and later strains having a lower risk for long-term COVID. There's also a little bit of evidence suggesting that if your initial symptoms of acute infection included central nervous system signs, including loss of smell, including loss of consciousness, or problems concentrating, using your brain well, and dermatologic problems as your initial sign, those may be predictors for having long COVID symptoms, which include mental health, cognitive, executive function problems. And it might seem strange that the dermatology may be a predictor, unless you remember that both the skin and the brain cells start with a similar embryonic group of cells. So the shared predisposition to CNS, central nervous system involvement with long COVID may be a reflection of the embryonic origin of those cells. Now, with long COVID, more than 50 different symptoms have been identified, ranging from, this is primarily we think of it as still a pulmonary infection with the coronavirus, so breathing, asthma, shortness of breath, pulmonary function problems, heart problems, kidney problems, skin problems. But among the most common, clearly at the very top for long COVID is fatigue, which in most studies affects at least 80% of people with long COVID. And a cluster of symptoms that's one of the other most frequent is brain fog, which in most studies affects about 25% of victims of long COVID. So why would a virus that infects the lungs, the pulmonary tissue, be something that's having brain effects on the long run? And there's at least 5 different degrees of likelihood among them, possibilities, including direct infection, neuroinflammation, microvascular and blood supply issues, stress and sympathetic activation, and psychosomatic, psychological sources for brain problems from long COVID. So jumping to the first one, direct infection, very clearly the coronavirus can infect the epithelium at the back of the nose. That's part of the olfactory system, the smell system. That's the one part of our, depending on how you count the eyes, one part of our central nervous system that's existing outside of the cranium. There are some reports that coronaviral particles have been found in other brain neurons and glial within humans who have been infected. That doesn't appear to be a widespread or huge numbers or amounts, but we don't know to what extent direct infection of nerve cell tissue may be playing some role in some individuals for the picture of long COVID. Much more attention and much more emphasis, and rightfully so, has been placed on neuroinflammation. So we know that the coronavirus itself was very effective at eliciting really strong inflammatory responses, that the cytokine storms, and for many individuals, particularly the healthy younger individuals who died from COVID, many of them were dying from overactivation of their own immune system. So this is a virus, again, that evokes strong bodily inflammation, and we know that the brain isn't completely protected from inflammation that's going on in the rest of the body. So there are many studies with measures of cytokines, other signs of neuroinflammation, other signs of gliosis or scarring within the brain. So there's good documentation that neuroinflammation is part of the process of long COVID. Third factor is microvascular. So we know coronavirus also triggered clotting, not in everybody, but way above background rates of blood clotting, and probably inflammation in the walls of small blood vessels, either which can cause cutting off oxygen supply and causing lesions in the brain. So both on autopsy and on MRI reports of living people, many of them display an excess number of little microvascular lesions compared to people who didn't get coronavirus. And again, that could be affecting nerve cell circuits and brain function. Fourth one is this mechanism of action is the stress and sympathetic nervous system activation. And so we know if you have ongoing either cognitive or emotional or even just physical problems, if you've never had to worry about breathing and now you have problems with breathing, or you have an arrhythmia of your heart or cardiomyopathy, that the stress from having had a coronavirus COVID infection can, in some people, increase sympathetic nervous system active overdrive and cortisol stress responses. And we know both excess norepinephrine, excess epinephrine, excess cortisol. In the short run, those are useful signals to the body. In the long run, they can be neurotoxic. And there's evidence of that in some subset of people with long COVID. And then, interestingly, the fifth area of psychosomatic origin for executive function and cognitive deficits in long COVID. So in the very early stages of the epidemic, when we didn't have a lot of data, we didn't have a lot of experience, the people who were reporting, I'm still feeling sick or I'm having any kinds of symptoms weeks or months after the initial infection, many of them were attributed by their doctors as psychosomatic, that this isn't really something going on except in their mind, not in their brain. Silly distinction. And that it's just because they're stressed out by the unknown fears connected with this virus. They're stressed out by the changes to our work lives and daily lives, sequestering in place, the working from home rather than in the workplace, the isolation from family and friends in many situations, or the forced proximity to people you might not want to be living with all the time. So in the early days, much of long COVID was dismissed as purely psychosomatic. And what's interesting is we've found at least these 4 other clear physiologic pathways which are probably contributing to a large component of COVID. Most of the studies are completely thrown out or not even looked at. Is there, how can we evaluate and and treat or address any psychosomatic aspects that some people are having for their long COVID. So I've been talking about just sort of a general brain infection, but it turns out that there are certain parts of the brain that are particularly susceptible to the coronavirus and to long COVID symptoms, therefore, and particularly the frontal cortex has come into attention. There's studies of people with hospitalized, so again, severe COVID cases, where we can see frontotemporal hypoperfusion, hypoactivation in at least some subset of people. That doesn't mean everyone. And there's evidence of gliosis, inflammation in frontal cortices, and some evidence in a few other studies that that's a particularly vulnerable area, and the executive function dysfunctions seen in long COVID strongly suggest that there is a prefrontal involvement. So before I launch into the cognitive testing and others, I'll jump into, there was a really interesting study done through the British Biobank. They had 401 individuals who they actually had MRI brain scans pre-COVID, before individuals got infected with the virus, and compared, again, 401 individuals who contracted COVID with close to an equal number, slightly fewer, 385, I think, who did not catch COVID, and they had a before and an after MRI about 3 years apart. And in this study, they found measurable shrinkage in the orbital frontal cortex and the parahippocampal gyrus gray matter in people who had the virus. So again, this is long-term anatomic. So this is not a huge, major effect. These are two areas which receive direct projections from the olfactory bulb. So it's thought that these are reflecting infection of epithelial tissues at the back of the ear and nose, and that this is then either just through having their input to those cells affected adversely and cut back, or maybe by infection proceeding along those circuits, damage to the areas most directly connected to the back of the nose. But also, this study found that in hospitalized individuals, so a subset of the people who had gotten COVID, who were more severe ones, they also found a greater reduction in gray matter thickness across the frontal parietal and temporal regions. So they found more substantial pervasive atrophy or shrinkage compared to the unaffected with COVID population. Again, this is not during active infection. This is, in many cases, a year or two after their infection they're showing. And again, it was not a huge change, but it was a statistically significant finding. And even more interesting or well done about the British Biobank study, they weren't just looking at the brain, the anatomy. They had some executive function tests administered, and they found that people who had symptoms, who had, so those who had been exposed to the coronavirus, on average, were performing a little more poorly on the executive function test. So there's a loose correlation there that changes in brain may be reflecting real changes in brain functioning. And the British Biobank study is only one of many that have been looking at executive function tests, so attempts to measure cognitive performance. So some of the studies looking at long COVID have relied only on self-reports, that I'm feeling less focused, I can't concentrate, my memory is shot, I'm getting lost or confused, I have less emotional control, I'm tired all the time. But many of them have also given tests which measure memory, which measure aspects of attention, which measure aspects of impulse control, which measure ability to plan and ability to change tasks or shift focus in tasks and shift strategies. And the overall general finding is that there is some correlation between subjective feelings, what you're experiencing or describing, and measurable decrements on cognitive testing. And particularly interesting, I'll quote sort of from two different studies. One found, quote, that impaired coding and recall of memory was defective in these long COVID patients, but in those same individuals, there was relative sparing of memory recognition, which to this group suggested that the damage, again, was prefrontally, again, more executive function, attention, whether you're attending to the material and it's getting into your brain, rather than a hippocampal storage of memory information. And that mapped really well with another study which said, and they're using slightly different terms and slightly different testing, the poorer memory performance was characterized by equivalent reduced accuracy in immediate and delayed recognition rather than by accelerated forgetting. And again, their interpretation was this was indicative of frontal cortex, prefrontal cortex, rather than hippocampal problems. So along the lines of that, there's a group at Yale, Arman Fade, I'm going to butcher his names. Arman Zadeh, Zadeh, who has focused and done research and collected research from others. His theory, and there's good data to back it up, is that the prefrontal cortex is particularly vulnerable. It's the evolutionarily newest part of our brain. Glutamate, which is the most common excitatory neurotransmitter, most common neurotransmitter overall, but it is an excitatory one, in the prefrontal cortex predominantly uses NMDA receptors, one subset of receptors, as opposed to AMPA receptors. These NMDA receptors seem to be vulnerable to a couple different toxins, one of which is cyanuric acid, which is a breakdown product of tryptophan, which is an amino acid that's used to make certain neurotransmitters. So there's neurochemical, neuropathological, and neuroinflammatory reasons why that frontal cortex may be most susceptible and may be creating ADHD-like pictures or worsening existing ADHD in the setting of long COVID. So I said earlier that there's some data. So for about the last decade in the US, about 16 million people year after year self-identified in U.S. Census Bureau reports as being disabled for physical or mental conditions. A few months after COVID started, that number started going up dramatically. So between 2020, mid-2020, mid-2022, that number jumped 1.7 million from a fairly steady baseline of the preceding decade. So these are people who are self-describing, not necessarily treated, not necessarily diagnosed by a doctor, but identifying themselves on survey as I am disabled, unable to do, my functioning so impaired I can't do what I can normally do. Clearly, that was connected to the corona epidemic. And of that 1.7 million, 1.3 million, so the significant majority of that group, identified that it was difficulty concentrating and remembering that was the reason for their impairment. So this is why I'm saying that there's certainly people with long COVID who have horrible lung problems, other heart, other organ systems, but the most common reason for disability from long COVID is the executive function deficits, is the brain fog, is the ADHD-like picture in people with COVID. So I think there's a good body of research support to support the three claims I made at the beginning. And interestingly, when I gave this talk live yesterday, we had individuals from each of these three categories. I didn't plant them, I didn't ask them to write in, reporting their own experiences. So one group is those who did have pre-existing ADHD, but who feel much more impaired, much more disabled, much more less able to function since contracting long COVID. So long COVID can exacerbate ADHD in people who are already symptomatic with ADHD. Two is that some people who had some ADHD symptoms but were never diagnosed, probably even if they had been evaluated, wouldn't meet full criteria, have moved from a subsyndromal condition of ADHD to full-blown ADHD because of long COVID. And three, there are some individuals who didn't report any substantial, significant ADHD symptomatology and who are not experiencing other mental health problems, so not depression, not anxiety, and who have a new full-blown ADHD-like picture. We may call this secondary ADHD. And interestingly, one of the case reports that was one of the first case reports of this came up was a Brazilian study. It was a Brazilian professor, 61 years old, again, no history of ADHD or symptoms like that, had COVID, severe enough to be hospitalized, had fatigue and I think gastrointestinal symptoms primarily for several months afterward. And in his case, almost a year after his initial coronavirus infection, without any other trauma precipitating causes, developed a full and robust, full ADHD-like picture. Scores on ADHD rating scales, I think, were in the mid-40s. And eventually, there were trials of Ritalin, Vyvanse. Vyvanse didn't work as well as the Ritalin. Ritalin caused insomnia. It was finally a combination of Ritalin and Wellbutrin, bupropion, which helped him come back close to his baseline mental health state and mitigated his significant impairment. So again, there's very few studies published so far on what's effective for the brain fog or ADHD-like conditions in long COVID. I know long COVID clinics that are using methylphenidate, using Vyvanse, lisdexamfetamine, using bupropion and Strattera, atomoxetine, drugs that are the standard treatment for ADHD. Those, at least from case reports and word of mouth, seem effective. Dr. Zadeh's group at Yale strongly recommends two treatments or two medications. One is an over-the-counter supplement called N-acetylcysteine. There's been some studies in it, particularly OCD, depression, and a few other mental health conditions. It's something your body does normally make in some amount. So N-acetylcysteine, or NAC, actually interferes with the synthesis of kynureninic acid. Sorry for butchering that. So that Yale group believes that substantially decreases the risk of damage in your frontal cortex or damage to the NMDA receptors. And they also recommend guanfacine. Guanfacine, of course, is an FDA-approved treatment for ADHD, but also has anti-inflammatory properties. There's case reports of ginkgo biloba supplements being successful in treating long COVID brain fog-like symptoms. This makes sense in that there's at least one very large study which looked at some benefit for Alzheimer's or dementia, which has a large neuroinflammatory component. There are other studies showing not showing effect in Alzheimer's, but ginkgo is not unreasonable to try. There's certainly lots of clinics are also using a host of CBT techniques, cognitive behavioral therapy, so certainly non-medication, sort of occupational therapy, tailoring treatment to whatever these specific deficits have, and training neurofeedback may be helpful. One other medication that I have a previous video about that would be interesting to try would be amantadine, which indirectly is boosting dopamine neurotransmission, so may be helpful for some of these executive function deficits, and has some and anti-inflammatory properties. So that's about all I have to say today. Next week's topic is body-focused repetitive behaviors, things like nail biting, skin picking, hair pulling. Don't have much to do there, and their connection with ADHD. So stay healthy, stay happy, and I'll talk to you next week. Bye.